Bioethical issues in pharmacoepidemiologic research. Examples of research scandals: failure to review and disclose research risks and potential benefits, and failure to obtain an explicit permission from research subjects. The goal of research has been to minimize research risks rather than minimizing the risks and maximizing the potential benefits on both the subject and the society. As a result, review by an international review board, the IRB, and full informed consent were developed to protect human subjects in clinical research. Applying these requirements in pharmacoepidemiology created some confusing modifications to these guidelines because human subjects in this type of research are different from those in clinical research. Risks are also different between these two types of research, where the main harm in pharmacoepidemiology is the violation of the confidentiality compared to health risks in clinical research. Guidelines have been developed to provide ethical structure to epidemiology, such as obligations to society, funders, employers, colleagues, and to the subjects, which is the most challenging one due to overprotection that makes ethical procedures difficult. The most important challenge in ethics of pharmacoepidemiologic research is that the investigators must protect patients' privacy and confidentiality in a way that accomplish research goals accurately and efficiently.
Clinical problems to be addressed by pharmacoepidemiologic research. First problem is the research. The U.S. National Commission for the Protection of Human Subjects defined research as any activity designed to develop or contribute to the generalizable knowledge. This is the standard by which a proposed project is assessed. This definition creates a challenge for pharmacoepidemiologic researchers and ethic review boards because it's not always easy to characterize the intent of the person who generates knowledge. The second clinical problem to be addressed by pharmacoepidemiologic research is the human subjects. The common rule, which is the set of federal regulations by the US, defines a research subject as an individual about whom an investigator, whether professional or student, conducting research obtains either data through intervention or interaction with the individual, or identifiable private information. For pharmacoepidemiologists, the key issue here is that the use of information that can be linked to an individual constitutes a contact between the investigator and the person. This is true even if the information was gathered in the past and no contact occurs between the investigator and the person. A key issue then becomes whether information can be linked to an individual. The third clinical problem to be addressed by pharmacoepidemiologic research is ethics review boards. In the US context, these are committees with at least one community representative, appointed by institutions that receive federal monies to conduct research. In other nations, there are regional or national committees that are appointed by professional organizations or governmental agencies. This requirement reflects the consensus that scientists and science could benefit from independent review of research protocols. They are responsible for consideration, comment, and guidance. They have also the power to review and reject all research that takes place in their institution or in which their institution's investigators are involved. In the US, a committee referred to as an institutional review board is required to review all research that is funded by all federal government branches that have signed on the common rule. The composition of these review boards vary widely across international boundaries. However, a consistent feature is the need for inclusion of expertise from outside the scientific community.
Privacy and confidentiality are two distinct concepts. Privacy refers to each individual's right to prevent access to documents containing personal information, such as medical records. Confidentiality refers to the individual's choice to allow a healthcare provider access to personal medical information, keeping the right to limit the transfer of information. It is based upon the right to privacy. But does the use of records without prior authorization constitute a violation of confidentiality, or does it constitute a risk of violation that depends on what is done with the information provided by these records? Here we can talk about two existing perspectives: communitarianism, which believes that the good of the individual is tied to the public good, whereas liberalism, which supports the idea that what is right exists prior to what is good. Minimal risk. Research risks are minimal if the probability and magnitude of harm or discomfort are not greater than those ordinarily encountered in daily life or during the performance of routine examination. However, this definition lacks a clear standard against which to compare the research risks: the daily lives of healthy persons or the daily lives of persons who might be subject of the research. Informed consent. The research ethics guidelines have stressed the requirement of a subject's informed consent. The subject must understand the nature of the research and must agree to participate voluntarily without inducement. Informed consent may be written or verbal. To make a right decision, a strict adherence to the principle of respect of autonomy is required. Thus, the subject's informed consent is perceived as an absolute requirement, keeping in mind that the potential impact on an individual is heavily dependent on social, economic, and medical factors.
Methodologic problems to be addressed by pharmacoepidemiology research. There are several methods that can be used in order to protect patient confidentiality. This is mainly done by controlling access to patient medical information. One method is universal consent. Upon enrollment in a health system, patient can either decide to reveal or conceal his or her medical records. Another method using electronic records management systems, the patient can decide to reveal certain informations and shield other private informations. For example, an electronic black box can be placed over medication history of antidepressants. Also, during a study, researchers can contact patients by calling them to provide informed consent for the use of their archived records. Applying those methods in pharmacoepidemiology may not really protect privacy to the degree that investigators and ethics review boards would hope, or may erode the validity of the research findings, thus affecting the generalizability to the population that stands to benefit from the research. First of all, one could doubt that these methods actually are masking patients' records and maintaining confidentiality. For instance, if every time researchers need to contact patients to have consent in using their medical informations, patients might think that their information is not going into research only, but also being abused by other purposes. Also, when researchers access patient information prior to receiving patient consent in order to decide the appropriateness of the data for their study, they are already violating confidentiality before getting the patient's approval. On the other hand, applying confidentiality can affect the validity of the research conclusion. For example, willingness to provide consent is generally not random and varies in ways that may bias study results. According to Ethics Review Board approved study at the Mayo Clinic, patients that accept to reveal their records may vary in age, gender, residence, or prior diagnosis. Also, when patients select what records to reveal, this can affect the research study results, for instance, by prohibiting the evaluation of a key medication adverse event association if the shaded information is in the pathway between the medication exposure and the outcome interest.
In record-based studies using data not directly identifying subjects, confidentiality policies regulate the use of information. In studies with identifiable records, investigators receive directions from local ethic review boards who are responsible of keeping the balance between research requirements and the subject's rights. In the United States, the HIPAA generated the privacy rule, which offers greater protection of privacy and restrictions to the use of data. The rule applies to cover entities or organizations that generate and manage personally identifiable health data. Under the new privacy rule, data sets that are de-identified can be disclosed and used freely.
De-identified data is defined as a dataset from which 18 specified items that could be considered identifiers have been removed, and a dataset which the covered entity knows will not be used alone or with other data for the purpose of subsequently identifying individuals. But in most studies, some of the 18 elements are essential for the research. Solutions for this problem include obtaining patient authorization, waiving the requirements for an authorization by the Ethical Review Board, and using limited dataset that contains some of the 18 elements considered identifiers if a data use agreement has been signed. Another solution includes coding the secondary data. However, the code cannot be disclosed. Potential ways to improve the quality and efficiency of Ethics Review Board include training and certification of board members, reducing the amount of paperwork for monitoring of protocols, and finding explicit funding that is appropriate to an Ethics Review Board's work.
The focus of the future should be to harmonize research regulations and set minimum standards for ethics review board competency and funding. Ethic review boards and investigators should balance ethical and methodological requirements in order to standardize ethic board review and boost their resources. There is a proportional relationship between research risks and subject protection, such as informed consent, where increasing the risk requires increasing the attention to full ethics, board review, and informed consent process. The value of the knowledge to be gained is an additional factor that should be considered by investigators and ethic review boards. Pharmacoepidemiology is considered a social service research should be exempted from the requirements of ethics board review and informed consent. The main problem is that it is not possible to weigh knowledge against confidentiality. So it is important to determine what kinds of procedures and practices combining confidentiality and obtaining knowledge.